Well, I hope this finds you in a good health. You'll be with me, Gilbert Gaston Charles, your clinical nutritionist and dietitian, and we'll be talking about standard operating procedures for nutritional management in end stage renal disease on dialysis, ESRD on dialysis. First, what is end stage renal disease? End stage renal disease is the final stage of chronic kidney disease when the kidneys have lost most of their function. Typically less than 15% of the normal kidney functions remains. The normal GFR, that's a glomerular filtration rate, is approximately 120 mils per minute, and that's giving us 108 liters per day passing through your kidney, being filtered and reabsorbed. And also the average urine output, on the other hand, average is only about 1.5 liters daily. The reabsorption of 178.5 requires a sophisticated tubular network. For glomerular filtration rate, less than 60 mL per minute signifies a kidney disease, of course. In end-stage renal disease, the GFR is less than 15 mL per minute. At this stage, the kidneys are no longer able to effectively remove the waste products and excess fluids from the blood or regulate electrolyte balance. End-stage renal disease requires either dialysis or kidney transplantation to sustain life. Causes of end-stage renal disease. Let's have a nutshell on this so that we can know what really can lead to end-stage renal disease. We have diabetes through diabetic nephropathy. We have hypertension. We have glomerulonephritis. All these conditions, they have a different pathophysiology on how they lead to end-stage renal disease, and it's a topic of its own, and we can discuss it some other time. We have kidney stones, the polycystic kidney disease, the autoimmune disorders. Some autoimmune disorders such as lupus can also lead to end-stage renal disease. We have the chronic obstructive uropathy. We can have an obstruction through the urogenital pathway, and this can result to end-stage renal disease too, regarding the condition itself. And also we can have some other more recurrent infections through your urogenital system towards the kidney. So all these can lead to end-stage renal disease in different ways. Well, what are the symptoms of end-stage renal disease? Number 1, fatigue. Feeling unusually tired or weak, even with adequate rest. Having an adequate rest but still feeling so tired. This can signify to you that you are actually having a kidney disease, something like that. Swelling, edema. This is accumulation of fluid in the legs, ankles, feet, or around the eyes. So when you see a generalized body edema, or you are starting to swell your legs, your lower limbs, this can signify that you are actually having a kidney problem, and it's just one of the symptoms. Shortness of breath, difficulty in breathing or feeling short of breath, particularly during physical activity. And this mostly signifies that we have water retention, and it can be actually leading to pulmonary edema little by little. Changes in urination. You have a decreased urine output, frequent urination, or foamy urine. This can signify you that there is something wrong with the kidneys. Loss of appetite, decreased interest in eating, or an intended weight loss. All this can signify that you have a kidney problem. And all of these, they have their different mechanisms on how they really actually come out as symptoms or representations of a person having end-stage renal disease or the kidney disease. And also the other thing is nausea and vomiting, feeling nauseous or vomiting, especially after eating. All these symptoms that I have mentioned, when you try to combine them, you may not have all of them, but you can have some of them. It is important to get to your nearby healthcare center and have your renal function test done. Difficult concentrating. This is because of the accumulation of the nitrogenous wastes, which can lead to a decreased concentration, thinking. So we have cognitive difficulties such as confusion or difficulty in focusing. Sleepy problems, okay? Trouble with sleeping or experiencing less rest leg syndrome. All these will signify that you have a kidney problem. So now what to do? It is essential for individuals with risk factors for kidney diseases such as diabetes, hypertension, or a family history of kidney disease such as the polycystic kidney disease and so forth to undergo regular screening and monitoring to detect and manage kidney disease early as possible, potentially preventing its progression to end-stage renal disease. Because we don't just get end-stage renal disease just like a boom. No. It's not like that. It starts little by little, so it comes from it becomes a chronic one. It comes little by little. Okay, yeah. So now let's go to our topic of today, and that's standard operating procedures for nutritional management in end-stage renal disease. And this can be applicable to all dietitians, yes, of course. And you're welcome for your comments and suggestions and other more. However, these will just be the standard procedures, just standard, yes. But still, we will have a case presentation on an end-stage renal disease patient on dialysis. So don't worry. After this session, we'll have another session on the presentation of a hospital case on end-stage renal disease on dialysis. So the standard nutrition management operating procedures for end-stage renal disease patients undergoing hemodialysis are crucial for optimizing their nutritional status and overall health. The following are the standards to follow in nutrition care for end-stage renal disease. We need to get the anthropometric measurements, so we do the anthropometric assessment. Anthropometric assessment is important in end-stage renal disease on dialysis. It is important to obtain, number one, height, the BMI of the patient. Knowing that you're dealing with an overweight or underweight patient or an obese patient is very important. The waist to hip ratios, all these, the ratios of the waist hip, they would give us a good picture of the body frame size of patient that we are dealing with, whether this person has a fat deposition excess or lower fat deposition, or is he normal or not normal. Yes. We also need the post-dialysis body weight. It is always a hectic in some of the health centers whereby patients do dialysis and they don't get the post-dialysis weight. While this is very important, the edema-free body weight is very important in managing end-stage renal disease or a kidney disease patient on dialysis. Very, very important nutritionally. Adjusted body weight. So this is the weight that we get after having some calibrations on the weight. For patients in dialysis, use adjusted body weight if the edema-free body weight is less than 95 or greater than 115% of the median standard weight in NANES2 data. We'll talk about these NANES2 data in other time, but this is the data that we use to adjust the body weight. Also see if the edema-free body weight is standard according to the relation with the height of the patient. Yes. We also need to do dietary assessment. This is just standard, remember that. Standard fall. Yeah. So on dietary assessment, conducting a comprehensive assessment of the patient's dietary intake, nutritional status, comorbidities, and metabolic requirements is very, very important. It helps to set smart goals that will be specific, attainable, and reliable with a specific time range. Yeah. So this helps to set the smart goals for your end-stage renal disease patient. All these assessments will be very, very important on the dietary assessment. You need to assess the intolerance, the allergies. You need to know how much calories has this person been taking before the onset of the condition or during the management. You need to know the nutrition status of the patient. You need to know other comorbidities that will be related to diet of the patient. Yes, and other metabolic requirements according to the BMR, the activity level, and so forth regarding to the guidelines. You have to reference from the guidelines, the practical guidelines. Yes. Well, let's talk about the protein intake. Ensuring adequate protein intake to maintain muscle mass and support wound healing and immune function while minimizing protein catabolism. The protein catabolism for patients on dialysis. We're not talking for the ones that are not on dialysis. We're talking about for the ones that are on dialysis. So right here, keep aside or keep pending those that are on conservative kidney management. We're now talking on patients who are on dialysis, whether hemodialysis. Yeah. So it is recommended protein requirement at 1 to 1.2 gram per kg from Kidoki 2020 guidelines, and this is a bit higher from the normal individual, that is 0.8 grams per kg per day. But for this person who is on hemodialysis, is requires 1 to 1.2 gram per kg. So as a dietitian, when you will be making your calculations, you can range at this range of protein. The calories intake, calculating and monitoring calorie intake to prevent malnutrition or excessive weight gain, considering 30 to 40 kilocalories per kg per day. That is very important. That is a reference from Kidoki 2020. It is also very important to evaluate the patient's tolerance regarding the response to the management. You know, some patients may not fit to this range of 30 to 45, okay, regarding their medical condition. So it is very important to assess the tolerance of the patient. How far can this patient get? And can this patient need other supplements or other stuffs? So that's very, very, very important to monitor the calorie intake, but that's the recommended standard range for patients on dialysis. So let's go in fluids monitoring. Providing guidance on fluid intake limitation to manage fluid overload and prevent complications such as hypertension and heart failure and pulmonary edema. A multidisciplinary approach must be used in discussion with doctors and nurses in reference to guidelines and patient's response. So for an end-stage renal disease patient, it's always recommended that you take the urine output and add either in a range of 500 to 750 mils. So if the patient is making an output urine of 500 mils, so we can have 500 plus extra 500. That would be the fluid intake, or 500 plus 750. So in that range, plus 500 or plus 750 mils from the urine output. That would be the fluid requirement. But also, please remember that you need a multidisciplinary approach. You need to make a further discussion with the bed nurse of the patient, the doctor of the patient, on how far we can set goals on the fluid monitoring, fluid requirements. Yes. So we also need to have electrolyte management. Monitoring and regulating electrolyte levels, including sodium, potassium, phosphorus, and calcium through dietary modifications and, if necessary, pharmacological interventions. So electrolyte management is a very important part that we all need to consider. Phosphorus limitations. Implementing strategies to limit phosphorus intake, such as avoiding high phosphorus foods and phosphates containing additives, and prescribing phosphate binders as needed, considering in a range of 10 to 17 milligrams per kg per day of phosphorus. Sorry, this must be micrograms. Yes. So most of the end-stage renal kidney patients, they present with hyperphosphatemia, and it is very important when you're making your diet plans regarding the nutritional requirements of the patient after calibrations and calculations. Then it is very important to monitor and limit our phosphorus intake. Yes, you need to have an exchange list of the foods that are high in phosphorus and low in phosphorus. So you better go for the foods that are low in phosphorus, and you should make at least in that range. So if my patient is having a high phosphate levels, so I would not hesitate to move with 10 micrograms per kg per day. Okay, yeah, I think that sounds very good as standard. Sodium restriction. advising on sodium restriction to manage fluid balance and blood pressure, including recommendations for low sodium foods choices and avoid high sodium processed foods, considering an intake of 1,000 to 3,000 milligrams a day of sodium. And this can also not include any added salt, dry salt, in the meals of the patient. Doesn't need any added salt. Yeah. Remember, when you add up salt, you also increase water retention for this patient. Water molecules move with sodium molecules. So reabsorption of the sodium will result to reabsorption of water again. And we have more water retention. Having more water retention, we can have a risk for increased blood pressure, a risk for pulmonary edema, a risk for other more complications. Yeah. Then, here we go again, potassium management. Providing guidance on potassium intake, restriction to prevent hyperkalemia, including avoiding high potassium foods and using cooking techniques to reduce potassium content. Yes. So as a dietitian, you need to know how to reduce potassium content from the food, but also which foods are better, the low potassium and high potassium foods. No, we have some high potassium foods such as banana, avocado. All these are very high in potassium, but you also need to know the low potassium foods, which can be very reliable to these patients regarding the biochemical results of potassium levels, but also full-time monitoring of the potassium levels. Micronutrient supplementation, prescribing or recommending vitamin and mineral supplements to address deficiencies commonly observed in end-stage renal disease patients, such as vitamin D, iron, and folic acid. Yeah, but also in hand with calcium, just not written here. But vitamin D, as long as is very important in facilitation of calcium absorption in the GI, then we need calcium too. We need calcium for these patients. Individualized nutrition. Developing an individualized nutrition plan according to the patient's needs, including protein, calorie, fluid, sodium, potassium, phosphorus, and other micronutrients requirements. You should consider renal exchange list and calculations for standard and effective diet planning. Also consider drug-nutrient interaction. Very important part, drug-nutrient interaction. Some drugs interfere with how nutrients work. Some drugs interfere with the absorption of nutrients, and some drugs may not work under presence of some nutrients. This is a very, very broad topic, but very important for any dietitian to know this part. So you need to develop precision medicine. That's regarding the genetic makeup of the patient, regarding the tolerance levels of the patient, regarding the height, age, weight, and all other assessments that you have done. Very, very, very important. So we cannot have a fixed diet for all renal patients or fixed diet for all overweight patients. We cannot have a fixed diet for all DM patients. Everyone has individualized requirements, and that's a point where dietitian is really needed to make an individualized dietary plan that will fit with the requirements of the patient. So this should be something very, very standard to remember when you're dealing with an end-stage renal disease patient. Do not use one plan for a patient A and the same plan for patient B. Patient A and patient B will never react the same to the diet, will never react the same to the management, will never be the same on dialysis. So that's the thing you really have to remember, and I really pound on that. Keep a lot of concentration on that point. Furthermore is monitoring and evaluation. Regular monitoring the patient's nutritional status, dietary adherence, biochemical markers, and anthropometric measurements, and adjusting the nutrition plan as needed. So a regular monitoring process will really help you to know the intolerance levels of the patient and how the patient responds to the diet and so forth. So this is a very important part. And patient education and counseling, providing ongoing education and counseling to patients and their caregivers on dietary guidelines, meal planning, portion control, label reading, and lifestyle modifications to support optimal nutrition and overall health. So, very important how you educate your patients. And do not expect that patients will respond very fast sometimes. They may not respond on the very first time, but you still need to have good counseling skills. So, this is a skill that every dietitian should learn. Interdisciplinary collaboration. Collaborating with other healthcare professionals, including nephrologists, other dietitians, nurses, and pharmacists, to ensure coordinated and comprehensive care for end-stage renal disease patient or for patients undergoing hemodialysis. So it is very important to have a multidisciplinary and interdisciplinary collaboration with other healthcare members on how you will manage your patients. The standard operating procedures should be implemented in combination with regular nutritional assessment and counseling sessions to support end-stage renal disease in achieving their dietary goals and improving their quality of life. Well, I would like to say thank you very much for your time. We really have been using a bit of 21 minutes up to now, and I hope it must be a very productive time that you spent here listening to me. Well, we are hoping to have another session on hospital case presentation on end-stage renal disease on dialysis. So these are the standards that we're going to really follow. And also, I would like to wish you a happy National Nutrition Month, March 2024. You were with me, Gilbert Gaston Charles from the University of Dodoma as a student of clinical nutrition and dietetics by now fourth year. Yeah, just a bit waiting to graduate, finishing up very soon. Yeah. Thank you very much and welcome for other more sessions. You can also visit my other videos on dietetics, healthy lifestyle, and so forth. I've posted a bit of them, not so much, but you can pass through them. And don't forget to subscribe. Yeah, very important, so that you can have everything on time. Thank you very much. Have a good time.